Thank you. It's great to be here today at the Champions of Wellness Virtual Summit. My name is Jina Sinskey, and today I'm going to discuss how to operationalize well-being at your institution. My learning objectives are to 1. Discuss the current state of clinician well-being and the effect of burnout on healthcare organizations and staffing. Next is to summarize concepts from organizational psychology to increase clinician engagement. And finally, we'll design an organizational plan for clinician well-being using a step-by-step approach. I want to start by addressing the elephant in the room. And that is that over the past few years, people have become cynical about the word wellness. And why is that? It's because well-being is a wicked problem. Now, what exactly is a wicked problem? Let's talk about wicked versus tame problems. A tame problem has a concrete answer, like an arithmetic problem. On the other hand, a wicked problem has no single solution and tends to be a social or cultural problem, much like public transportation. And this is a map of the public transportation system in Boston, which is also known as a T. Similar to wicked problems, you may have heard the term VUCA times, which stands for volatility, uncertainty, complexity, and ambiguity. This pretty much sums up the current state of healthcare and the world we live in. One characteristic of a wicked problem is that every attempt at a solution comes with high stakes. This is because each implemented solution leaves traces or unintended consequences that cannot be undone. So every time you miss the mark, it can lead to further dissatisfaction, demoralization, and disengagement. I want to emphasize, though, that this doesn't mean that we shouldn't try to solve the problem. It's just that the problem's not simple, and every problem we're solving is a difficult one. Many of you are familiar with the metaphor that clinicians are the canary in the coal mine. In his editorial in JAMA, Thomas Schwenk stated that physicians in 2018 are the proverbial canary in the coal mine. While the canary may be sick, it is the mine that is toxic, and caring for the sick canary is compassionate but likely futile until there is more fresh air in the mine. Now, the first iteration of well-being initiatives were heavily focused on the individual. You can give the canary a gas mask to make it more resilient, but ultimately the canary will not survive unless you improve the air quality in the coal mine. And individual-focused interventions without organizational efforts to improve the work environment inevitably breeds resentment and resistance. This is because there is an incongruence between the organizational leadership's words, "We value your well-being," and actions, "We are not fully invested in your well-being." This can lead to gaslighting or victim shaming. Now, the truth is, clinician burnout is not a resilience issue. Resilience refers to the ability to adapt and bounce back when things don't go as planned. And clinicians actually exhibit high levels of resilience. There was a survey of more than 5,000 physicians and individuals in the general U.S. working populations, and they found that doctors had significantly higher resilience scores than the general employed population. And they also found that having the highest resilience scores were not protective of burnout. So what should we do about the canary in the coal mine? We need to move on to Wellbeing 2.0. So in addition to an individual approach of resilience and work-life integration, which is equivalent to this gas mask, we need a systems approach of improving the work culture and environment, and this is equivalent to making the coal mine less toxic. This is reflected in the Stanford model of professional fulfillment, where 2 of the 3 items focus on systems as culture of wellness and efficiency of practice, and 1 of the 3 focuses on the individual as personal resilience. How do we define well-being? Well-being is not simply the absence of burnout, it is something more. Professional well-being comes from being satisfied with our jobs, finding meaning and fulfillment in our work, feeling engaged while at work, and having a high-quality working life. Well-being is also not about toxic positivity, aka pretending that everything is fine when it is so definitely not fine. Well then, what is well-being? Well, it's about making sure that the good outweighs the bad every day. In essence, every day should be a net positive for your well-being so that over time things get better and not worse. And to make this happen, well-being needs to be a factor in decision-making at all levels of the organization. And now, why is well-being an urgent issue? And it really comes down to this: severe staffing shortages in healthcare. We all know this, and so does the public, with articles in the popular press such as these showing how healthcare workforce shortages are affecting patient care. Now, I live in California, where water is very precious, so I'm going to use the analogy of water in a bucket. At some point, we seem to have enough staff to maintain the clinical workload. However, clinical expansion began to cause staffing shortages by effectively increasing the size of the bucket. Now, we have a leaky bucket, i.e., depletion of the healthcare workforce caused by retirement, attrition due to burnout, and a shift from people working full-time to part-time. And you may all recognizing this happening at your own institutions. In addition, the faucet filling the bucket is fixed and you can't fill it faster. Currently, starting with college, it takes anywhere from 4 years, for example, to train a nurse, to 15 years, for example, to train a neurosurgeon. And I'm not even counting the extra training such as fellowships. So these shortages lead to a vicious cycle, since the healthcare professionals who remain face even worse staffing shortages, leading to more well-being issues. Well-being issues have repercussions for patient safety. This is a report from ECRI, a patient safety organization. In 2022, their top patient safety concerns were 1. Staffing shortages, and 2. COVID effects on healthcare workers' mental health. Over the past decade, we have learned much more about clinician well-being, yet there is still a gap between well-being theory and practice. And as I mentioned earlier, Wellbeing 2.0 includes a systems approach, and providing institutional support is critical. A study on burnout in practicing anesthesiologists found that anesthesiologists who did not feel supported at work had an odds ratio of 10 of developing burnout syndrome. In other words, they were 10 times more likely to have burnout syndrome if they did not feel supported at work. This is a scary statistic. It also provides us with a great opportunity to mitigate burnout through better institutional support. The good news is there is an entire field of study dedicated to providing organizational support. Organizational psychology refers to the scientific study of behavior in the workplace and the application of psychological principles to enhance well-being and performance, with the goal of improving employee recruitment and retention. I want to introduce the job demands resources theory, which is central to organizational psychology. Job demands refer to challenges in the workplace that can lead to burnout and ultimately negative outcomes for the employee and the organization. Examples include an unmanageable workload and lack of control. On the other hand, job resources and personal resources refer to factors that mitigate burnout and increase engagement, leading to positive outcomes for the employee and the organization. And here are some examples of job resources that I will discuss today. This is by no means an exhaustive list. So let's start with psychological safety. Now, this is the definition of psychological safety by Amy Edmondson, who is a Harvard Business School professor and coined the phrase team psychological safety. She says that psychological safety is a belief that one will not be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes, and that the team is safe for interpersonal risk-taking. Now, a key element of psychological safety is giving someone the benefit of the doubt. This is the essence of the basic assumption, a core value developed by Harvard's Center for Medical Simulation to help create a psychologically safe learning environment for participants. And they state that we believe that everyone is intelligent, capable, cares about doing their best, and wants to improve. So now let's talk about organizational justice. In my conversations with organizational leaders, many are disheartened since they say that no matter what they do, well-being seems to be a losing battle, since we cannot give everyone everything. And I wholeheartedly agree that with our limited resources, it is impossible to give everything to everyone. And this is where organizational justice comes in. Fairness has been shown to emerge as a quality in children as young as 1 year old. And I'm sure many of us have heard a child say, "That's not fair." When people sense unfairness, it can create this sensation in your gut that things are simply not right. And in fact, there are studies demonstrating that perceptions of organizational justice can predict turnover intentions in healthcare professionals. There are three types of organizational justice: distributive, procedural, and interactional. Now, let's say we're providing scribes for a clinic. Distributive justice refers to how resources, in this case scribes, are allocated, and people can use three rules to judge whether an outcome is fair: equity, equality, and need. Distributive justice determines employee satisfaction with the outcome itself, i.e., which clinics were allocated with scribes. Now, procedural justice refers to the policies and process applied to how these decisions were made. A few criteria include consistency, lack of bias, and representation of stakeholders. This determines satisfaction with the system itself. And finally, interactional justice refers to how people feel they are treated by others. There are two types of interactional justice. Interpersonal justice refers to perceptions of respect, and informational justice refers to whether people received adequate explanations about how these decisions were made. Interactional justice determines satisfaction with the relationship. Now, even when the outcome is not as desired, in this case for clinics who did not receive scribes, procedural and interactional justice can serve as a buffer to help preserve a sense of fairness. Next, I'll talk about social support. There are four types of social support. Emotional support, which is kind of what you think about when we say social support: caring, empathy, active listening. Next is appraisal, which is affirmation and self-evaluation. The third type is instrumental, and this refers to tangible goods and services as well as tangible aid. And finally, we have informational, which is advice, suggestions, and information. Emotional and appraisal lie within the realm of the individual, while instrumental and informational support lie within the realm of the organization. For example, let's say there's been an adverse patient event. Here are some ways to provide social support to the individual involved. Emotionally, colleagues can listen empathetically to the person. So for appraisal, colleagues can remind them that they are a good clinician because inevitably they may have periods of self-doubt. From an organizational standpoint, instrumentally, the institution can provide relief and time off after an adverse event, and also provide information about the second victim phenomenon, which tends to happen to healthcare professionals who are involved in an adverse patient event. I want to emphasize that each person is different, and social support after an adverse event should be provided in the way that the individual desires. Now let's talk about job crafting, or autonomy, which is the process of employees redefining and reimagining their job designs in personally meaningful ways. There are three types of job crafting: task, relational, and cognitive. Task means you add, drop, change, or alter tasks in your job description. For example, I'm an anesthesiologist, and I'm also passionate about well-being. As an anesthesiologist, my primary job is to take care of patients in the operating room. I've added tasks in my role as Vice Chair of Wellbeing that brings me great meaning in my work. Relationally, I also regularly interact with other well-being champions. And finally, cognitively, as an anesthesiologist, I see my job as supporting my patients safely through a critical event and to provide them comfort during a stressful experience. And this also brings me great meaning in my work. Now, here's an example of job crafting in academic medicine. Let's start by looking at why healthcare professionals choose to go into academic medicine. They choose academic medicine because they have non-clinical interests, most common ones being education and research. And the distribution between these three roles as clinician, educator, and researcher can vary by person due to different interests. Departments need to provide flexibility and opportunities for faculty to pursue their interests. And this is not limited to academic medicine. Healthcare professionals in private practice may balance time they spend in different roles, including those as clinician and those as an administrator. Now, given that well-being is a wicked problem, solutions are not one size fits all. And therefore, I decided against providing a laundry list of well-being solutions. Much like how the T cannot be directly translated to the city of San Francisco, the work we do at UCSF is not directly translatable to other institutions, which is why I want to present the framework and approach that form the basis of our solutions. We apply the 6 areas of work-life model, which was developed by Drs. Christina Masloch and Michael Leiter. The first area is workload, so this refers to sustainable workload and realistic recovery, for example, between shifts. Next is control, so choice and flexibility. Third is reward, so a culture of appreciation. Fourth is community, having a supportive work community and colleagues. And fairness, which is respect, social justice, and diversity, equity, and inclusion. Finally, we have values, where we talk about meaningful work. And it's been shown that the degree of mismatch that exists between the individual and their workplace in these 6 areas of work life is predictive of burnout. We've also developed a novel approach to well-being that incorporates principles of human-centered design, quality improvement, and implementation science. Human-centered design has been proposed by the National Academy of Medicine as a way to approach clinician well-being, while quality improvement is a familiar concept to many clinicians, and many well-being problems can actually be considered to be a flavor of QI. Finally, implementation science is a scientific study of methods and strategies that facilitate the uptake of evidence-based practice and research into regular use. This approach is becoming more important as we gain a better understanding of what needs to be done, yet there remains this gap between the words and actions when it comes to organizational well-being. And this is a worksheet that we use to apply the quality of life improvement approach. We call the approach quality of life improvement, or QOLI, and the QOLI approach centers on 3 questions. Why, what, and how? Why is this problem important? What are we going to do about it? And how do we keep improving? And I'll cover each phase in detail in the following slides. So why is this problem important? Phase 1 is all about coming up with the problem. So first of all, you need to build your well-being team. As in QI, well-being teams need to include members with 3 kinds of expertise: system leadership, technical expertise, and day-to-day leadership. So sponsors provide system leadership, while frontline clinician well-being champions provide technical expertise and day-to-day leadership to drive these well-being initiatives forward. And now, per implementation science principles, well-being teams should include individuals in the target group, i.e. frontline clinicians, because you need to have people who are in that setting. And so you incorporate these different satellite teams depending on what setting you're working in. It's been shown that a formal appointed role combined with protected time can increase the effectiveness of frontline clinician well-being champions. I want to pause and talk about the role of the well-being champion. The well-being champion is not the social planner or the person who brings you wellness pizza. The well-being champion is an advocate for frontline clinicians. Their main responsibility is to facilitate two-way communication between frontline clinicians and leadership. So therefore, the well-being champion should be 1, accessible and approachable to frontline clinicians, and 2, be able to share candid feedback with leadership. At our department, we have a well-being team. So first being the vice chair, which is my position, hybrid of sponsor and frontline clinician well-being champion. We also have a steering committee with directors of faculty well-being and learner well-being who also have protected time. In addition, since we have multiple campuses, we make sure we have representation from the different sites, including site champions, and we also have task forces, some examples being financial well-being, coaching, and community building. We also have close collaborations with diversity, equity, and inclusion and academic affairs. So now that we've built the team, we need to assess the landscape. You can do an internal assessment and an external assessment. Internal assessment must include visits to the clinical setting. This is known in QI as going to the Gemba, where the Gemba stands for the real place, or in this case, where the clinical work is done. You can also do focus groups, interviews, and surveys. For an external assessment, you can do a literature review, or if there's no literature available, you can do knowledge sharing with well-being thought leaders, either within your institution or across the country. So when I bring up surveys, people often ask me, what about survey fatigue? And I don't think I'm exaggerating when I say that many of us are burnt out. And when I talk to other well-being champions, everyone is hesitant to conduct well-being surveys due to survey fatigue. This issue actually came up in a National Well-being Director course I took recently, and the instructor told us that he does not believe in survey fatigue. And we were all quite taken aback. What he meant was survey fatigue happens when people fill out surveys and nothing happens. This breeds a lack of trust, and when the next survey comes around, people are less likely to respond. Now, as I said earlier, two-way communication is essential. Therefore, we have adopted the you said, we did format for well-being updates. Now, during our quarterly faculty meetings, our chair shares well-being updates in a slide like this one. There has been positive feedback from our faculty, and our chair likes that it keeps him accountable. So once you've done the internal assessment and the external assessment, now we need to define the problem. It may be tempting to just jump straight to solutions, but please don't. This is the most critical step. You are not going to solve the problem if you can't identify the correct problem. As Albert Einstein stated, if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem and 5 minutes thinking about solutions. So here comes the problem statement. The problem statement takes you from a problem into a way to start thinking about solutions. Problem statement starts with the phrase, how might we? And this is a tool from design thinking or human-centered design. Problem statement needs to be narrow enough to be actionable, but broad enough to encourage creativity. So, let's say that the problem that you've heard about is organizational decisions are made suddenly and without clinician input. For example, scribes. The problem statement might look something like this. How might we enhance transparency in organizational decision making? So now we have the problem. And we're going to move on to phase 2. What are we going to do about it? Or how do we come up with solutions? So here's our problem statement. How might we enhance transparency in organizational decision making? And the first step is to generate ideas. It can be all kinds of crazy ideas. You just put them down a list. So here's the list that we came up with. Once you have those ideas, you need to prioritize the ideas. And this is my favorite step, since, as I said earlier, we have limited resources. An essential step to operationalizing well-being is to identify which interventions have the highest yield for the level of investment. So the two methods are, one, the sweet spot. So in this case, this is from human-centered design. You want to find things that are desirable, so something that people want, viable, makes sense from a financial standpoint, and feasible, things that are doable. And when you meet all three criteria, you are in the sweet spot. So the second method, the pick chart, should look familiar to anyone who is in quality improvement. And this is where you look at the level of difficulty, which is the x-axis, versus the payoff, which is the y-axis. And from here, you really want to focus on the implement, which basically means you have a low level of difficulty with a high payoff, so a high return on your investment. All right, so going back to our example of transparency, let's say you prioritize these ideas using the sweet spot and the pick chart category, and town halls and focus groups come out as feasible, viable, and desirable, and also in the implement category. On the other hand, seat at the table on organization-wide committees may be feasible, they are viable and desirable, and also considered a challenge. Whereas stakeholders voting on all organizational decisions is none of those three and is also in the kill section. So therefore, when you think about do we move forward, the top two are definite yes, the third one is a not now, and the fourth one is a firm no. So let's go on to phase 3. How do we keep improving? So this is about testing your idea and just continuing to iterate. So let's decide we're going to test the town hall idea, since that was one of the go-aheads. All right, before you start the testing, you really want to figure out what does success look like. And in this case, we'll say it's increased physician understanding of organizational decisions. And then you have a testing plan. You say, okay, who, what, where, when. All physicians, monthly virtual town halls, where the entire organization comes together, and this is going to happen between January to March 2023, January to March 2024. You just think about a time you want to do this. So from there, you want to think about your outcomes, and this is a Plan, Do, Study, Act or PDSA cycle from quality improvement. There are 3 outcomes, as I said. 1 being adapt, where you refine and run another test. 2 being adopt, where you test on a larger scale. And 3, abandon, where you do not perform more testing on this idea. So if we go back to our table of solutions, we talked about town halls and focus groups being a yes. So let's say we've finished those. And now we want to work on the next step, which is a seat at the table on organization-wide committees. At any point, I would say you should probably work on about maximum 3 different types of well-being initiatives as a given time, but you should always have in the back of your mind how you're going to move this forward. So for me, one example of a not now thing that we worked on over a long period of time was PACU holds. And as I said earlier, I'm an anesthesiologist. I work in the operating room. And this is an example of how clinicians and leadership can work together on well-being at the systems level. For those of you who are not familiar with the term PACU hold, it is essentially a throughput issue. When the recovery area, also known as the PACU, can no longer accept patients due to lack of beds or nursing staff, the patient must remain in the operating room under the care of the anesthesiologist. This means that the next surgery cannot proceed, or if it is the last case of the day, nobody gets to go home. PACU holds affect well-being for several reasons. For clinicians, increased workload because you need to stay in the OR, decreased control and values because patient recovery happens in the OR with the anesthesiologist, whether they want it or not, and you lose meaning in work since this is really not a work that meant for an anesthesiologist. PACU holds are also bad for OR efficiency and hospital finances, so the hospital administration doesn't like PACU holds either. So at our institution, we worked with perioperative leadership to create some additional beds in the non-operative areas, such as CT, MRI, and also a short stay unit. We also asked the cardiac catheterization lab to recover their own patients after 5 p.m. And as a result of this work, PACU holds did decrease. So now what's next for us? At UCSF, our next goal is really to address perioperative well-being. To date, our efforts have mainly been internal to our department. However, anesthesia is not an island, and it is naive to believe that you are not affected by your environment, which in my case is the operating room, and this includes anesthesiologists, surgeons, and nurses. As an anesthesia department, there is only so much you can do in the perioperative environment without buy-in from other stakeholders. Now, this is our perioperative well-being team. We are working on we are working on incorporating nursing as well, but right now we have anesthesiologists, myself, and our director of QI and director of faculty well-being. From surgeons, we have a director of the Center for Mindfulness in Surgery, interim director of QI, and associate vice chair of faculty affairs and chief experience officer. We also have research support because we want to know whether these interventions are effective. So we have a mixed methods researcher and a qualitative researcher. Now, this is all well and good, but I get this question a lot. What if we don't have a well-being infrastructure? Well, believe it or not, we are all leaders in our own way. So you want to think about your sphere of influence, and you can make or break someone's day. I believe that somewhere in between individual and systems approaches, there is an interpersonal level of well-being interventions. So revisiting the 6 areas of work life, here are some examples of how we can improve the work environment on an individual level, both for ourselves and for others. So for workload, we can think about work-life integration or work-life harmony, setting healthy boundaries. For control, trying to build autonomy for ourselves and others. Appreciation and positive feedback to increase the reward. Community showing support, active listening. Fairness, which comes to respect and allyship, and finally values, which comes to job crafting and meaning making. I also want to share a few concrete steps that we as individuals can take to improve our well-being that are from the May 2022 U.S. Surgeon General's advisory. So there are 5 of these. Number 1 is to learn to recognize signs of distress, mental health challenges, and burnout in yourself and in your colleagues. So this comes down to maybe asking a simple question like, how are you doing really? Next is to stay connected and reach out for help. So, and we do this with our residents. You ask them to identify a list of 2 to 3 friends or family members who you can lean on and call during moments when you feel overwhelmed. You also want to prioritize moments of joy and connection, and this may mean returning to old hobbies, spending time with friends and family, or trying something new when you're ready. You also want to get back to basics with good health habits. It's always important to maintain the basics. We are in healthcare. So eating well, sleeping well, exercising, limiting alcohol, and harmful substance use. It's been shown that a 10-minute walk outside in sunlight can actually help improve your energy and focus. Finally, use your voice to advocate for positive changes in your workplace. And this is, there are many ways to do this. And one important way is to participate in well-being committees, or if there is no well-being committee, maybe you form it yourself. I want to reiterate, well-being is advocacy. If you are not at the table, you are on the menu. And so therefore, it's important for you to reach out on a national level and really build that network to be able to advocate for yourself and your colleagues. I wanted to share this resource compendium from the National Academy of Medicine for Clinician Wellbeing. You can use this QR code over here. And finally, I just wanted to summarize by saying clinician well-being is an urgent issue. We need individual and systems approaches, and a systematic approach such as the quality of life improvement can help achieve these goals. Every day, it may seem like we are barely making progress, and this can be discouraging. If there is one takeaway from today's talk, it's that every step we take towards enhancing the well-being of ourselves and our colleagues, however small, can lead to big improvements over time. Thank you for your attention. I would love to continue this conversation, so please stay in touch. Thank you.